Namaskar to all. Now today we going a chapter number 11 part number 2nd. So last time we discussed a human eye, a very important part of the humans because with the help of this eye we showing a colorful world. But suppose we are not care about our eyes, so normally number of problems should be found in our eyes, so that time we are unable to showing a clear image. So friends, today we discuss about that topics. So types of human eye whenever some problem should be created. So first part we showing it is a myopia. So myopia means now that time the any human to showing a long distance object not clear. So first discuss how can possible and how can we the correction of that myopia. So first, myopia is also known as nearsightedness. Means now that time in this have we showing a clear image of near object, but we are unable to showing a long distance object. A person with myopia can see a nearby object clearly, but cannot see distance object distinctly. A person with this defect has the far point near than infinity. Such a person may see clearly up to a distance of a few meters. So we discuss here now regarding this problem, we are showing a near object very clear, but sometime we want showing a long distance like an infinitive. So that time we are found some problems. So now how can possible? So ray light coming from the long distance and passing from the lens, and they are made it not retina but the front of the retina. So here friends, a very simple, because in exam time you showing here again now ray light coming from long distance and they are not made on the retina but his form in front of the retina. So this defect may arise due to excessive curvature of the eye lens or maybe elongation of the eyeball. So friends, suppose we are found of this effect. So what is the correction? Solution. So definitely that time we using a one concave lens, and after passing a ray from the concave lens, so this ray meet directly on retina. So definitely we remove this myopia. So it is a very important and a very useful question, because in the exam time, definitely now two problems in our eyes is main. One of the problems should become a compulsory with diagrams. So here now 3 marks we completed. Now second, it is a hypermetropia. Now again, so we showing in the like a difference in the myopia, so some opposite path. Now, hypermetropia is also known as farsightedness. A person with hypermetropia can see distant object clearly but cannot see nearby object distinctly. Now is the opposite. Now in this effect, we showing a long distance object may be a clear, but that time we are unable to showing a near object. So the near point for the person is further away from the normal rear point at 25 centimeter. So how can possible? How can this effect created? So then definitely the ray light coming from near distance passing from the lens, but they are not made on the retina, but they made focused close by the retina means the behind on the retina. So this defect arises either because the focal length of the eye lens is too long or the eyeball has become too small. So what is the correction? Solution. So now regarding this effect, we put a one convex lens near a eye. Then after passing the ray from the lens and they meet on the retina directly. So that time we showing a clear image on near also. So it is a second. Like what is a hypermetropia? So friends, here you showing a difference between the myopia and the hypermetropia. It is useful to retain in the exam time. My suggestion, you learn only the one topic like myopia. And second, definitely you retain with the opposite. Suppose you read both the topic in the same time, so exam time, no number of confusions should become. So first we discuss the difference. First myopia. So myopia is also known as nearsightedness, and hypermetropia is also known as farsightedness. In the myopia, a person with myopia can see nearby object clearly but cannot see distant objects distinctly. In the hypermetropia, a person with a hypermetropia can see distant object clearly but cannot see nearby objects distinctly. In the myopia, a person with this defect has the far point near than infinity. Such a person may see clearly up to a distance of a few meters. In the hypermetropia, the near point for the person is further away from the normal near point like a 25 centimeter we discussed in the human eye point. Now in the myopia, in a myopia eye, the image of a distant object is formed in front of the retina. We showing in our image also, not at the retina itself. But in the hypermetropia, this is because of light rays from a close by object are focused at the point behind the retina. So in the myopia, how can possible? So this defect may arise due to excessive curvature of the eye lens or elongation of the eyeball. And the hypermetropia, how can possible? So the focal length of the eye lens is too long or the eyeball has become too small. So what is the correction in both? In the myopia, these defects can be corrected by using a concave lens of suitable power. In the hypermetropia, this defect can be corrected by using a convex lens of appropriate power. So friends, simple, and I say now one of the topic in the exam time must become in 3 marks range. So you try here. Now third point is a presbyopia. Now this effect come whenever the human age passing a 60 up. So that time we are found this type of effect. So we say the power of accommodation of the eye usually decrease with age. For most people, the near point gradually recedes away. They find it difficult to see nearby objects comfortably and distinctly without corrective eyeglasses. So this defect is called presbyopia. Means now the human, now they are unable to showing both the distance like a near as the long distance. So this defect is called presbyopia. It arises due to the gradual weakening of the ciliary muscles and diminishing flexibility of the eye lens. So sometimes a person may suffer from both myopia and the hypermetropia. So such people often require bifocal lenses. So friends, here a very important question, bifocal lens. It is one of the lens have using a two type of lens like a concave and the convex both in the only one bifocal lens. And every time in the exam time, this definition or this MCQ should become. So friends, tick mark here. Bifocal lens we using for the defect of the presbyopia. A common type of bifocal lenses consists of both concave and the convex lenses. The upper portion consists of a concave lens. It facilitates distance vision, and the lower part is a convex lens. It facilitates near vision. So these days, it is possible to correct the refractive defects with contact lenses or through a surgical intervention. So now, here we showing a three type of defects. So friends, now start. We are showing here a animation video for the two type of like a defect like a myopia and the hypermetropia. So friends, you showing a video to hear, enjoy and understood very easily.
Myopia. Origin of the word. It comes from the Greek word myops, meaning short-sighted. These people cannot see distant objects clearly. Anatomy. Before we describe myopia, let's compare the eyeball to a camera for better understanding. When we take a picture, light after reflecting from an object enters the camera and passes through following. Firstly, it passes a transparent glass in front of the aperture of the camera. Then secondly, it passes a camera lens that helps us in focusing light rays. And lastly, there is a camera film on which light is focused for a clear picture. Eye is somewhat similar as when we see an object. Light after reflection from that object enters our eye through. Firstly, it passes cornea, the transparent curved front part of the eye. Then secondly, it passes through the crystalline lens that helps us in focusing light rays. And lastly, there is the retina. Light-sensitive receptor cells in the posterior part of the eyeball on which light is focused for a clear image. Definition of myopia. It is a form of refractive error, inability to refract, bend, focus the light rays properly, in which parallel rays of light, i.e. coming from a distinct object, after entering the eye, are focused in front of the retina instead of on retina with eye muscles at rest. Causes. Curvature. Increase of curvature of cornea or lens causes light rays to be focused in front of retina and hence myopia occurs. Axial. Increase in axial length of eye increases the converging power and cause light rays to be focused in front of retina. Index. Increase in refractive index, i.e. light bending, focusing power of the lens, for example in cataract. Positional. Anterior displacement of lens, e.g. after trauma. This again causes light rays to be focused in front of retina. Types. Congenital, from birth. Simple. Most common, starts from 5 to 10 years till 15 to 20 years and is mostly due to curvature or length problem of eyeball. Pathological. Hereditary, progressive, and is due to degenerative changes in the eyes. Clinical features. Symptoms. Blurred vision. Half-shutting of eyes. Parents of child will tell. Outward deviation of eye. Divergent squint. Normal patients require to move their eyes inward while focusing near objects. This is not required in myopic patients, causing their eye to move out intermittently or constantly. Signs. Prominent eyeball, as eye is big. Retinal changes in pathological myopia. Diagnosis. Retinoscopy, a handheld device that throws light in the eye and allowing us to observe its movements and reflection, hence helping to confirm the refractive error. A-scan, a small ultrasound probe that throws ultrasound waves in the eyeball and then detects their reflections or echo timings, calculating the eyeball length. Treatment. Unlike the camera, maximum 2/3 focusing in an eye is done by the transparent front part, cornea, while the rest, 1/3, is done by the lens. So, while treating these patients, we have to decrease the focusing power of the eye so that the image is formed on the retina instead of in front of it. This can be done by using either a diverging lens like glasses, contact lenses, or some surgical procedure. Surgical treatment. Flattening the central part of cornea. This includes different methods that were changed and advanced, depending upon reduction of side effects and recovery time and improvement of degree of vision. The surgeries included in this category are radial keratotomy, photorefractive keratectomy, LASIK, laser epithelial keratomylosis, LASIK, laser in situ keratomylosis. Other surgical treatment options are lens extraction, contact lens implantation.
Hyperopia. Anatomy. Before we can describe hyperopia, let's compare the eyeball to a camera for better understanding. When we take a picture, light after reflecting from an object enters the camera and passes through. First, a transparent glass in front of the aperture of the camera, then secondly, a lens that helps us in focusing light rays, and lastly, a film on which the light is focused for a clear picture. Eye is somewhat similar, as when we see an object, the light after reflection from that object enters our eye through, firstly, cornea, the transparent curved part of the eye. Then, secondly, through the crystalline lens that helps us in focusing the light rays. And lastly, the retina, light-sensitive receptor cells in the posterior part of the eyeball, on which light is focused for a clear image. Definition of hyperopia. It is a form of refractive error, inability to refract, bend, focus the light rays properly, in which parallel rays of light, i.e. coming from the distinct object, after entering the eye, are focused behind the retina with accommodation, eye muscles at rest. Key features. This refractive error has three key features. Image is formed behind the retina. In normal people, image has to be focused on the retina for it to be clear. Parallel light rays, the rays that only come from objects at 6 meters or beyond, must be used for assessment, as when objects come closer than 6 meters, light rays start to diverge, changing their focus. This is why we place Snellen's chart at 6 meters. Eye must be at rest. Just like a DSLR camera's focusing power can be changed by rotating its zoom lens, eye changes its focusing power by changing the shape of its lens, with the help of contraction and relaxation of certain muscles located inside the eyeball. These muscles must be at rest to correctly access the eye's focusing power. This is also the reason why we use cycloplegic or muscle paralyzing drops before estimating the amount of refractive error. Misnomer. Both hyperopia and myopia have abnormal distant vision, i.e., they cannot focus distant objects clearly. But the unique thing about hyperopia is that if these patients increase the power of their lens by contraction of certain intraocular muscles, they can focus the image accurately on their retina. This will result in excessive and continuous use of intraocular, ciliary muscles in order to keep the image focused on the retina, resulting in pain. Also, when they try to see near objects, their eyes will require even more focusing power, which these muscles can no longer provide, hence causing near objects to become blurry. So, a lot of hyperopic patients, not all, with less degree of hyperopia, will say that they see distant objects clearly, but they have pain or discomfort in their eyes, or their eyes get tired, and also near vision is mostly not that good. Hence, these patients are mistakenly called farsighted. Cause. 1. Curvature. Curvature of cornea or lens is flatter than normal. 2. Axial. Short axial length of eye. 3. Index. Decrease in refractive index, i.e. light bending, focusing power of the lens, e.g. in cortical cataract. 4. Positional, posterior displacement of lens, e.g. after trauma. 5. Aphakia, Absence of lens in eye. Therefore, eye cannot focus light rays on retina. Types. 1. Total hyperopia. It is the total refractive error, calculated after complete cycloplegia, intraocular muscle paralysis, induced by certain drops. 2. Latent hyperopia. Amount of hyperopia corrected by the focusing power produced due to normal tone of intraocular ciliary muscles. It is usually 1 diopter. 3. Manifest hyperopia. It is the remaining portion of hyperopia, divided into facultative. Amount of hyperopia corrected by the focusing power produced due to active contraction of ciliary muscles. Absolute. Amount of hyperopia that cannot be corrected even by contraction of ciliary muscles. Clinical features. Symptoms. Eye straining or discomfort. Asthenopia, including eye tiredness, pain, headache, or mild photophobia. Blurred vision with eye straining, when muscle contraction attempts but fails to correct hyperopia. Blurred vision only, when refractive error is high and cannot be corrected at all by muscle contraction efforts. Inward deviation of eye, convergent squint. Normal patients require to move their eyes inwards while focusing near objects. This is enhanced in hypermetropic patients, causing their eye to move inwards intermittently or constantly. Signs. Small eyeball. Corneal diameter may be small. Retinal exam might show false changes due to distortion of image when hyperopia exceeds 5 diopters. Diagnosis. Retinoscopy. A handheld device that throws light in the eye and allowing us to observe its movements and reflection, hence helping to confirm the refractive error. A-scan, a small ultrasound probe that throws ultrasound waves in the eyeball and then detects their reflections or echo timings, calculating the eyeball length. Note, at birth, all eyes are hyperopic, plus 2.5 to plus 3 diopter, i.e., light is focused behind the retina. As the eyeball grows and at about 6 to 7 years age, eyeball is of normal size and light is now focused on the retina, or emetropic. In some people, it continues to grow, causing myopia, or light is focused in front of retina. Treatment. Unlike the camera, maximum 2/3 focusing in an eye is done by transparent front part, cornea, while the rest, 1/3, is done by the lens. So while treating these patients, we have to increase the focusing power of the eye so that the image is formed on the retina instead of behind it. This can be done by using either a converging lens, e.g., non-surgical treatment, glasses, contact lenses, or some surgical procedure. Surgical treatment. Making the central part of the cornea more curved. This includes different methods that were changed and advanced depending on reduction of side effects and recovery time and improvement of degree of vision. PRK, photorefractive keratectomy. Remove corneal epithelial cells by a solution. Then use laser to reshape cornea, i.e., making it steeper, and then apply a bandage contact lens. Side effects include pain and recovery is in 1 week at least. It corrects 2 diopter hyperopia. LASIK, laser in situ keratomiliosis, corrects up to 4 diopter, a famous and frequently performed surgery nowadays. In this procedure, a device, keratome, slices a flap of cornea, 160 micrometer. Laser is applied to change the corneal shape, and then the flap is repositioned. Advantages. Advantages over other procedures. Absence of post-operative pain. More rapid visual rehabilitation. Conductive keratoplasty. It involves getting radiofrequency energy to corneal stroma, causing change in its shape. Can correct low to moderate hyperopia.